Welcome you all for this webinar organized by Dept of PMR, SVNIRTAR, in association with Odisha Association of PMR and Indian Association of Physical Medicine Rehabilitation. Friends, we all treat spinal cord injury patients in our rehab unit day in and day out. When we receive a patient in our rehab unit, especially chronic spinal cord injury, the first part is to assess the patient about severity, about the grade, and by that we use different classification system, assessment system for assessing the spinal cord injury. Out of that, ACI grading is very common. It is universal accepted, and we all do assessment of spinal cord injury by using this ACI grading system. And this is a system which is gradually evolving till now. Also, there are different versions are coming up at a frequent interval. Today, we have one discussion on that ACI grading, that is expedited version of International Standard for Neurological Classification of Spinal Cord Injury. That's the second version. This electronic version helps in determining the NLI and ACI grade with reduced number of exam items. Today we have with us Dr. Abhinav Singh, Assistant Professor of ESIC Medical College, Patna. We are also fortunate to have him today for this discussion. He had also presented last talk in same spinal cord injury sexual rehabilitation. It's probably in December 2024. Maybe after 1 year again we are listening to him. One more talk on spinal cord injury. He is actively involved in spinal cord injury rehabilitation, which is well manifested by his involvement in different societies at state level and international level on spinal cord injury rehabilitation. For example, he is a content reviewer for use of different medical equipments for spinal cord injury under ASIA. Also, he is also member of Rehabilitation Standard Committee of Asia. He is mentor in International Continent Society, and he has written a good chapter on aerodynamics for a textbook of IAPMR. And he is also mentor of special interest group for cancer rehabilitation in ISPRM. And also he is the first person who has established this the cancer rehabilitation in Patna. He has done his fellowship in palliative care medicine. So I don't want to waste time. This is an interesting talk on spinal cord injury assessment. Without wasting time, I invite Dr. Abhinav Singh for his presentation. Over to Dr. Abhinav.
Uh, Thank you very much for a nice introduction, Dr. Pabitra Kumar Sahoo, sir. Before we go into the details, I will also always remember my PG days whenever I am seeing the patient. There are a lot of abbreviations that will turn up. Even in this slide, you can see there are three abbreviations, which I'm quite sure all participants won't be able to spell out correctly, but most will be able to spell some part of it. And these three are: one is SVNIRTAR, Swami Vivekanand Institute, Swami Vivekanand National Institute for Rehabilitation Training and Research. It took me a whole day to remember it. Quite possible. So there are sometimes what happens that we get big name. Pavitra Sahu sir may be knowing the SVNIRTAR full form, but what about the others? Same thing applies to ESIC MCH. It is again a big name, and for few it may be difficult. It is Employee State Insurance Cooperation Medical College and Hospital Bihta in Bihar. Now the biggest name which we are going to discuss is EISNCSCIV2. V2 is version 2. That is quite clear. This E can be electronic, can be elevated, can be eradicated, can be something, something, something. This version 2 has come after eradicating the version 1, that we must remember. And it is one of the smarter way to classify spinal cord injury. Why it is, we will just look into it. One of the most famous quotes which you will all will remember: "Sabka saath, sabka vikas, sabka vishwas, sabka prayas." it is applicable to this also, because the moment some standard thing comes up, then at that point of time, it has to be first made by all sections all over world. Then it is for the welfare of everyone, and it has must have the Vishwas, or understanding of each and all of us, and it has always a collective involvement or collective work is there. Why I'm saying this, that if something which is applicable in US should be applicable to the Indian population as well. If something is happening in Europe, that standard of examination should be applicable to anywhere in Bihar or Odisha or Kerala or anywhere. So that standardization is always important. So that is a very hard work, and a lot of things with, at some point of time, everything keeps churning up. If you all remember, once we used to have a basic mobile set, from landline to mobile set, mobile set to Android to iPhone, and everything is evolving day by day. Similarly, standardization of any examination is also evolving. So what is this EISN CSCI V2? So it is a expedite international standard neurological classification of a spinal cord injury. It was for version 1 came in February 2020, and after March 2025 it has been clearly told by ASIA that it is no more applicable, because there were some issues regarding the sensory part of the S1 examination and the anorectal examination. So that has been known, and I don't think it is of much use to discuss more about the version 1, because version 2, whatever is applicable to us, we go ahead with it. No one discusses about the landline now. All of us will sit down and discuss about the latest mobile which is in the market and which is going to come up. Why expedited version? I will be using word E for expedited version of the ISNCI, and full ISNCI as full version in most of my talk. So why do we need this training? In before doing this E version, we need a full ISNCI SCI, because बाप तो बाप ही रहेगा. We always have to remember, whenever we are in trouble with E version, we have to again shift back to the full version. We must remember this point. Always remember it, that without understanding the fuller version of IS and CSCI, you cannot do the E version, because there is always, whenever you are looking for a shortcut and a shorter version, there is always a chance of some mistakes to happen. So what are those mistakes and everything we will discuss in detail. So this is the international standard for neurological classification and spinal cord injury. This we have to always remember. This is the latest version that was in 20, that came up in 2019, and after that it has been. So everyone must master this full version before shifting to other, because in 2019 non-key muscles, non-traumatic spinal cord injury and everything were added in at that point of time. So we have to master this worksheet at any cost before shifting to the other version or the newer version or the E version. So before I go into this version, I will just share one more thing. This is quite available, easily available. Is it visible? This key sensory points and key motor points for the PGs must go through it, must be at the tip of your tongue, because C2, C3, these key versions are always there to be seen and followed up. So C5, C6, this is available on the ASIA website. Clearly available. Just go to the e-learning section, and again followed by this motor version. Motor version has to be at the tip of the tongue, and we all must remember this motor version of the ACLs. So these two are must learn. Before going to that, this full version format. So why this Kolaveri Day? I always remember this Tamil song, because this was the first word I came to know in the Tamil was Kolaveri. Why do we need it? Another trouble for the PGs to be uh, screwed in the class, or to be asked in the examination. Another added burden. Is this the purpose, or it is for the welfare of all of us? Because what happens, for a proper examination of the fuller version, we need 30 minutes to 45 minutes of proper examination. In between, patient may get irritated. Why are you doing so many things? Why are you asking so many questions all the time? Every this side, that side, right side, left side. You are using cotton, you are using pinprick. So there is always a risk. In between, patient may take break and our rhythm may break. So why this version is needed? Because it is a quick screening exam for early determination of neurological level of injury and ACI impaired skill. These two are the main motive. So as early should screen that. And if suppose a patient is under follow-up of our follow-up in OPD after rehabilitation, so there is no need for until unless we have to redo or some new complications has turned up. So at that point of time, we always have to remember the most important thing before examination is to have a proper history. History taking becomes very important. While talking to the patient gives us everything. So when to go for E version or the full version, it is the history that becomes very, very, very important. That will determine our approach towards the patient. And if a patient is chronic, stable, coming off for regular follow-up, so we can use this version. Suppose a patient is of acute injury, is in the ICU, and we have to monitor for the neurological changes because there drastic change in neurological level of injury while recovering from the ICU. By the day from ICU, they come out to the ward or to the rehab center. There is quite a drastic change. So for that, we will need that. And if a patient is undergoing inpatient rehabilitation at that point of time, because at some point of time we may need to assess it either at midterm assessment or at the end of assessment, that time you will need a fuller version. But in between, intermittently, if you think some changes are happening, then at that point of time you have to decide whether to go ahead with the fuller version, yes, or the E version, or which one. So there is a fixed testing protocol. Again, as I said, fuller version is most important thing for understanding sensory motor examination. Testing is E version is same as the full version. So that has to be, if we need a worksheet, which worksheet to be used for this E version of the, or then for that worksheet is only the full version. Only in the comment section you have to write it is the EISNCSCI. That's it. So same workshop has, what thing has to be done. What should be the position of the patient? Then the position of the patient has to be supine. In earlier version, it was in the sitting, it can be done in sitting position, but there were a lot of issues with the incomplete evaluation or examination. So it has been made that it should be supine and patient should lie lateral if there is a need for rectal examination or rectal examination has to be done. So again, is the E version ZPP or zone of partial preservation becomes bit difficult. Although zone of partial preservation, earlier it used to be only for the complete injury. Now it has been also included for the incomplete injury. So how to approach, whether to go for motor testing first or sensory testing first, if sensory light touch or pin prick, how to approach that. So it is a clear cut written and a plan that it should be MCP. I have made this abbreviation, again another abbreviation, but it is a shorter version. When I say MCP is M for motor, C for cotton, and P for pinprick. This should be the sequence, not the other way around. So motor testing, again all the 10 key muscles has to be taken care of. And when to do this non-key muscles? If there is any suspicion of incomplete injury or AISB. So if B is suspected, how will you suspect B? Suspicion of B will come up by taking history and some exam. So whenever there is something called presumed motor level of injury. So what is this presumed motor level of injury? It is that suppose a patient is having C5 and power is less than 3 by 5. So what will happen? How we will decide the determine at that point of time, we have to consider it as C4, one level higher. Okay, for the presumed motor level of injury. And always we have to consider it rostrally. Rostrally, whatever is the 3 by 5 motor power, that point has to be considered as a motor neurological level of injury. So rostral as you all know, nose. So with the nose, and this nose ring, all of you it will be easier to remember. That's why I've put on this photograph. So remember the rostral side. Okay. And again, if the rostral side, which one to presume? So whichever is the comparatively higher rostral side, that will be the motor neurological level of injury. Okay, so that has to be again kept in mind. Which side is the we have to consider as neurological level of injury? Whichever side rostral is, if it is same, well and good. If it is not same, whichever is on the higher, consider it as a motor neurological level. So again, which I said, presumed motor level, it comes up when if C5 motor power is less than 3.5, then it is presumed to be C4. And if it is L2, it is considered as less than 3 by 5. If L2 is less than 3 by 5, it is presumed. I'm again using word presumed. Ilios is weak, less than 3 by 5. Presume it as L1 because we are not doing motor examination and we have not yet done the sensory part. And always keep in mind this E version is time saving. So something has to come up which will save our time. So this thing at presumed motor level has to be kept in mind. So 10 sensory testing. Again, sensory testing, when to do, left side to do, right side to do. We are confused how to start. Even that point has to be taken kept in mind. So sensory testing, either right side or the left side, it has to be decided again on the motor neurological level. When I say motor neurological level, whichever side rostral is higher side, then start the sensory examination from C2 on that side, whichever is the higher side. Suppose if both the rostral sides are same, then what to do? Only solution is use your conscience. Right side, left side, you decide. Or if you are confused, toss it up. So that becomes important. Now, how to proceed in it? Again, light touch is more important, then followed by the pinprick. While light touch, how to proceed in light touch? Light touch is start from C2 and come down till the dermatome score of changes from 2, score of 1 or 0 is found. And the segment corresponding to the presumed motor level is reached and has been tested. If the presumed motor level is reached, then after that there is no need to proceed further. In full examination, you have to write and examine everything, every part, even motor level is reached or whatever you have done. Then again, if motor level is, we know about the light touch, then comes this pinprick. How to do the pinprick? Again, remember, we are doing only one side. If it is rostral side is a motor power is motor neurological level injury on the right, suppose, then we are doing on the right side only. Then comes the pinprick. Pinprick again, no need to start from the C2. Then pinprick can be started on the same site at the caudal dermatome. That has two, the level at least two, had a score of 2 or a normal on light touch. Then go 2 steps, consecutive dermatomes with the normal pinprick sensation are identified. So we have to keep in mind if cotton first, then followed by pinprick. Pinprick, no need to go from C2 to everything. Go to the cotton light touch level, then go 2 steps, 2 dermatome above that. Next, if that level is done, how to approach the contralateral side? Now, contralateral side, no need to again go from come from C2 to till the neurological level of injury. Okay, motor neurological level of injury. Then in that case, light touch on the contralateral side, it is at the dermatome that corresponding to the most caudal dermatome of the two consecutive dermatome on the first side. First side, whatever you are getting from the that sensory level, above from that below, go to again 2 consecutive dermatomes above that. And then again, rostrally, I start testing rostrally 2 consecutive dermatomes. Light touch and are there identified. Then that level is reached. We have to consider that okay. Suppose it was at T12 on the normal side. So on the contralateral side, on the other side, we will go T11, T10. After T10, we will see if it is 2 by 2 at T11 also, T10 also, then we will consider it as T12 only. Then again test the pinprick on the second side at the most caudal dermatome that was tested normal on light touch. Always remember light touch is very important in the prior step. And then similarly, we find out all the levels. And again, rosterly until two consecutive terms. If it can be at the T, suppose it is T12, it can be at T12 on both sides. It can go up to T10 or T11. Accordingly, we have to find it out. So how to determine neurological level of injury? So we have to assume that all untested dermatomes rostral to the tested ones are normal. That has to be assumed because we have to finish it fast. First examination has to be done a bit fast. So we assume that all dermatomes rostral to the tested ones are normal, and this conventional or conventional IS and CSCI criteria, whatever is being used, has to be used for the criteria for NLI, neurological level of injury determination. It is a more or less more. It is 100% same, not even more or less. And the neurological level of injury, which is most caudal segment with intact sensation and anti-gravity muscles, function strength, provide that there is a normal sensory and motor function rostrally. So this is the NLI that we have to calculate. So how to find out the impairment scale? This is something which is being a lot discussed from version 1 to version 2, and it is under discussion how to minimize that part. So S4, S5 sensory testing is done, light touch and pinprick. S4, S5. Again, cotton light touch has to be used first, then followed by pinprick. Light touch if any sensation is present in any side. Always remember, any sensation of light touch or pinprick on any side at S4, then the remainder of S4, S5 sensory testing can be omitted. For example, if while doing the light touch on the right side view of S4, S5, we are getting sensory is present, then there is no need to test for the other side, left side, not at all needed. Okay. And if the sensation is completely absent, both sides we tried light touch and pinprick, if it is absent, then in that case, we have to check deep anal pressure and the voluntary anal contraction. Both are needed. If any sensation is, and another point that has to be for impairment scale is, if any sensation is present at S4 and S5, okay, any side, but motor is not preserved. Where motor is not preserved, it is more than 3 levels below the motor level on the either side. Any side, if it is not preserved, then we have to check for the voluntary anal contraction, otherwise not needed. If motor power is preserved more than 3 levels below it, even for the non-key muscles, it can be omitted. If any sensation is present and motor is preserved more than 3 levels below the motor level, then deep anal pressure and voluntary anal contraction can be omitted, because it is presumed that if some motor power is present 3 level below the motor level, then it is quite possible that sacral plexus is intact or voluntary anal contraction and deep anal pressure is present. So how to determine impairment scale? A, S4, S5 sensation is absent bilaterally. Deep anal and voluntary anal contraction is absent. As simple as it is, it is same which we had been following all throughout. In AISB, if deep anal sensation or any S4, S5 sensation is present and there is no motor preserved more than 3 levels below the motor level on either side, which include voluntary anal contraction, key and non-key. Here non-key is very important, because non-key we have to always suspect if in the history, if it is ASIA B, if there is chance, always go for the non-key muscles also more than 3 levels. If A and B has been ruled out, then it is quite clear that injury severity is motor incomplete. If the moment patient is out of A, he is in B, it is motor incomplete, quite sure. Now, whether it is C or D, then if it is C, if it is less than half of the muscles are 3 by 5 or greater, power is 3 by 5 or greater, then it is considered C. And if it is more than half of the muscles are 3 by 5 or greater, it is considered as ASIA D. So why we should always know, always remember, I will suggest to PGs, remember the fuller version first, then use the E version. E version, although it is quick, preliminary evaluation can be done. and periodic monitoring for changes of neurological level of injury and AIS during acute care and can be done. But why we should need a fuller version? For if you are doing any research work, fuller version is always needed. And if it is for establishing definitive neurological classification of acute SCI, spinal cord injury, and admission to inpatient rehabilitation, definitely at the time of admission you have to do it. And so if there is any suspected neurological changes with acute or chronic spinal cord injury, at some point of time what happens, there will be some edema in the spinal cord that will start subsiding and patient will start improving. You will see a drastic change. So at that point of time, you will need the fuller version of ISNC SCI. And if there is any classification other than neurological level of injury, AIS or motor scores are needed, even peripheral neuropathy is now also considered. So at that point of time, fuller version of 2019 becomes important. And again, presence of non-testable exam items or suspected presence of non-spinal cord injury affecting exam finding, everything has to be always taken care of. And as I said, clinical trials definitely a fuller version has to be used. So to summarize it, I will call it MCP. Always remember motor first, cotton second, and pinprick third. This has to be the sequence. And many a time, if uh, we are new, if remember the PT days, we may end up pricking very deeply, and patient may bleed. So that part has to be always taken care of because there is loss of sensation. So always I will say summary is MCP. Remember it. This is the best way to remember. And these are the references. References are mainly from the ASIA Spinal Cord Injury Organization Learning. And ASIA, this is the latest version that has been uploaded, and anyone can go through it. So if there is any queries, I will be more than happy to discuss it.
Thank you, Abhinav, for your beautiful presentation clarifying for assessment of spinal cord injury using ACS scale. This is very common and most useful for all practicing physiatrists as well as all students. Especially, it's so essential when you want to discuss with somebody with a peer group or you discuss with other professionals related to spinal cord injury. This is one of the common scale which everybody understands as far as spinal cord injury rehabilitation is concerned. So let me check any queries. Any comments using sir? I can see he has joined. Ramachandran sir also has joined. Sir, any comments or compliments or any additional things you want to like to say, sir?
No, no, actually, he has spoken so well and so confidently with nice pictures to remember. I don't think I can add anything. Thank you so much.
Thank you, sir. So one silly question sometimes asked, you said that for SEIB, S4 S5 sensation and DAP must be present, and back that time we have to check for the voluntary anal contraction. Is there possible that when S4 S5 will be present, sensation will be present, but DAP will be absent? Is it possible?
I don't think so. It is possible. I don't think it will be very bit difficult because it is that this is the one of the presumptions that is being made. If S4 S5 sensation is present at any point, D panel pressure will be present. So whenever we are examining for the D panel pressure, any side if pressure is present, we consider it as a positive. Even at some point, I see few people prescribing it as weak DAP or strong DAP. I don't think there is something like that. It is only DAP present or absent. If S4 is present, I think some pressure will be present. DAP will be positive, sir. Present, sir. And that's why this is the reason this they have used this for the classification part. If there is some S4 S5, if it is present, they consider it as positive. No need to go for deep section sensation checking.
How early one can use ACS scale after injury? Somebody has just had a
It's
spinal cord
really a good question.
injury.
I think it is as soon as possible. If you have to first and foremost thing, if a patient is in emergency, the most important is to follow the ABCD criteria. And again, the history. Patient has to be stable enough, and then we can start. because that is a very important part, even in ICU or in emergency, whenever we are saying it, that will help us first prognosticate and follow the progression, how the patient is progressing, how the level of injury is progressing. I think it should be as early as possible, because that is the one of the purpose of ACR grading, because we don't need to change the position or posture of the patient every time. So
Mm.
it can be examined when patient is lying supine, we can examine it. And that was the one of the reasons for giving this, coming up with this idea of key muscles and the idea of this key muscles. Because we don't need to go for thorough neurological examination, because it will may be detrimental if spine or vertebra is not stable. We may end up worsening the condition. So ACR can be examined anytime.
What ACI suggests how frequently one can examine to prognostic, whether it's monthly or any time. Is there any time interval that is at least this is the time period through which we can reassess the using the ACI scale?
I don't think so, sir. Any time scale, although I have not searched it, but I think it should be any time. That's why history taking becomes very important. We have to keep talking with the patient. When patient is inpatient, rehabilitation is happening, patient will himself come up and say, this is the improvement that is happening. Now I can feel some sensation. I am able to feel my motion is coming out, but I cannot control it. All these things patient will come up and saying. I think whenever we are rehabilitating a patient, three times is a must: at the time of admission, when we are doing the midterm assessment, and at the time of discharge. Because for example, sir, if acute injury is there, there will be drastic change. There's always a chance of drastic improvement in neurological level of injury. Especially some surgeries has been done, and spine stabilization has been done. So the moment there will be some edema, hematoma around it, it will start subsiding. Then again, it will start improving. And especially if it is in the, I remember one case of cervical injury. At that point of time, patient had a good surgery. All of a sudden, patient has a very good improvement. Then there was some movement and some surgical site infection, and patient deteriorated and had a problem. So at that point of time, we need to consider everything. Edema was there, edema wasn't, and hematoma was there, infection and pus all came up. So I think it should be done. No hard and fast rule for spinal cord injury, although it helps us, ACR grading helps us to in predicting the outcome. So three times minimum if we are doing for the rehabilitation. Post-operative, as many, not as many, but I think weekly we should do. Especially if a patient is in ICU, then definitely cervical injuries and all has to be done regularly.
Okay, so now few questions has come up now in the chat box. One question should the expected person be preferred in acute care situations where the patient is not stable enough or not cooperative enough even at the first SC examination?
See, if a patient is not cooperative, it will be very difficult. Reason being, we have to ask everything. You have to ask the patient to move his arms, move his wrist. So if it is not cooperative, ACR grading will be difficult. We have to wait for the patient to stabilize. Cognition has to be always good. Sensory examination you cannot do without cognition. You will one time patient will say yes, 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 I can feel. Other time you will try to cross check. He will say no, I am not feeling. So one thing, patient has to be cooperative. It is a must in acute care situations. So at some point of time, if you go to emergency, patient will be really irritated. So developing the good communication skill becomes very, very, very important, because the patient's life, spinal cord injury patient's life changes within a second. Few seconds ago he was walking, and now he is not walking. Within seconds it's happened. So he cannot feel anything. He cannot. So psychological issues will be there. So we have to wait for that patient to be cooperative. And at that point of time, first thing is stability. He should start realizing his disease, and then our communication skill definitely will work.
Yeah, next question. Post decompression surgery, how early AS is reliable or stable? Just you said that once you decompress the spine for stabilization, all hematoma, everything came out, then the compression effect will be less, spine gets stabilized, cord also injury, subsequent injury became reduced, it should improve. So, what's your take? His question is
Yeah.
post decompression surgery.
Post decompression surgery, RDS is always reliable and stable because it is helping you to just understand what is happening inside the spine or the vertebra, because you don't know what is happening, whether patient is worsening or there is some other hematoma is going a higher side. So do it as early as possible. Even the spine surgeons are doing it. So that you can prognosticate, you will be able to understand the progression. So progression, definitely do it as early as possible at some point of time, because nowadays even if after surgeries, decompression surgeries and all, we can start rehabilitation when the spine is fixed and sutures are cut off. I think it can be started.
In order to differentiate between complete and incomplete in a limited time, should we straightway go and check for S4, S5B, DAP, and VAC, or go from cranial to caudal in conventional way?
It is always a conventional way. You should never go do for that. Never do that, because as far as five, why we want to know about complete or incomplete? First thing, complete or incomplete comes later. First is the level of injury.
Yes.
For example, if someone only caudal epidural, cauda equina is there, why do you want to go for everything? No need for going for everything. So always go for the level of injury, then comes the complete or incomplete. Even if you don't take the history properly, you will be able to differentiate between complete and incomplete. Now, in incomplete, question arises whether it is B, whether it is C, or whether it is D. Otherwise, complete, incomplete is simple. History, can you feel anything? Nothing. That's it, done. So neurological level of injury is more important. If you ask, all the combined effort has to be there. We should know the complete and incomplete part as well as the neurological level of injury. So write down, it has to be always, rectal examination has to be always last thing to do.
During spinal shock period, can SCR charting be reliable for prognosticating the patient?
Yes, it can be. Because again, as I said, a spinal shock patient will be coming out. You are following up. So a lot of patients are there. ACI has got nothing to do with whether patient is in shock or not. Now, earlier it was even traumatic. Now even traumatic part is not taken care of. It can be non-traumatic part also. ACI examination can be done. So if it is shock, it is really good. So step by step, you will be able to understand whether patient is coming out of shock or not. So definitely it is a reliable chart.
Yeah, one question to suggest to give you some example of case scenario for better understanding.
Okay, for that better understanding case scenario, if you want to know, the best thing is to go for this. There is a chart on the website of ASIA. Okay, there are 25 cases given along with the answer. So even if at some point of time I feel I have not put my brain on this ASIA chart, I will go ahead for it. If you sorry. For example, okay, let me give you the case scenario, whatever I could make out. Any level of injury. Suppose it is L1 level. Okay. So what I will suggest, go to the learning center. I hope my screen is visible to everyone.
Yes, yes.
So what I suggest, there are 25 plus cases in the ASIA website. Go to spinalinjury.org, go to the learning center. So in the learning center, what you will see is there are a lot of ISNCSCI resources. So most important key sensory points, key motor examination guide, and classification workbook practice cases are there. So if you click over there, there are with 6 and 7. If you click here, you will get a lot of cases for practicing. So there, if you see, it is 27 pages. So this is case 1, case 2, everything is there. So you have to practice it. Again, if you go back, there are with workbook practice and answer can be done. So now suppose, as you said, I will just presume there is one patient with level of injury at L2 and motor power is less than 3 by 5 of L2. So this one again, 58 pages are there with the answer. So we can go through it, everything. So because full version, all 58, I will suggest PGs take out one day a day, do one case, 2 months, you can become expert of this fuller version. So again, as I will say, so suppose presume that this is the L2 level and power is less than 3 by 4, 5 on the right side. Okay. And that is the level. So presumed motor level becomes L1. If the presumed motor level becomes, sorry, presumed motor level becomes L1, and then we have to go for the sensory testing. In sensory testing, we have to decide whether to go for the right or the left. So L1 right side. Suppose L1 on the right side, L2 has a power of 4 by 5 on the left side, but on the right side it is L2 has power less than 3 by 5. So presumed motor level will be L1 on the right. So sensory testing, we will start with the cotton from the C2 level and go down till we get a sensory testing of score of 1 or 0. This 1 or 0 can be at L1, can be at T12, can be at any other level. So wherever we are getting 1 or 0, well and good. Suppose we are getting a dermatome till L2, we are getting score of 2. Then consider that as the sensory level
Yes,
of
Prof.
injury. No need to do any further testing. Suppose we are getting now this suppose this has 2 by 2 dermotome for the light touch at L2 level or L1 level, then now start going higher up towards the caudal or the rostral side with the pinprick. Suppose it can be at 2 by 2 at L1, or it can be at T12. Suppose it is at the T12, 2 by 2, and then again start going up. We are getting 2 by 2 we have to check till T12. Then consider to 2 by 2, then again go to the contralateral side. On the contralateral side, if we are going, then light touch has to begin from the L1 level, because on the right side the level of 2 by 2 sensory was at L1. Then again start at the L1 on the left side, again start checking sensory 2 levels above that. If you are getting 2 levels above that, T11 and T12, then L1 will be the final level of injury, final neurological level of injury. Suppose on the left side you are getting at 2 by 2, 1 by 2 on the left side with the cotton, then go for the pinprick, 2 levels above it, and finish it off. Now again, S4, S5 testing has to be done. Start with always cotton has to be, this light touch has to be started from the C2 onwards. Okay, and then C S4, S5 sensory touch, any side. If any side we are getting on the right side, we are getting S4 light touch is present. No need to do any further examination. No need to deep anal pressure or voluntary anal contraction. And if there is some power at L3 or L4, some motor function is there up with power 3 by 5 below the L2, no need to check voluntary anal contraction. Okay.
Okay, so somebody has to go through, for students at least they have to go through this practice book for
Definitely, definitely.
understanding. And this has to be done frequent interval, otherwise we'll forget.
Yes, otherwise one will forget everything.
Yes, yes. Last question is, so is the exact use of case of this expected
E
version
version, okay.
to only in OPDs for follow-up patients?
No, it has to be, it can be done in OPDs, but at some point of time, can be done in the ICU also. It has to be done in emergency. Emergency is always remember high tension zone. We don't have that much of time to follow that. So at that point of time, it becomes important. At least we will have a gross idea about the neurological level of injury, so that we can start the management of the patient from that point of time. Suppose if it is L2 or L3 or low higher up, what to do? Where will be the vertebra fracture also that you can assume? Where is the spinal cord injury? Which area needs to be stabilized first, or be cautious in approach while moving the patient? Everything starts from the emergency itself, and you can't spend a half an hour to 45 minutes in emergency examining a patient, and the patient is critical. Always ABCD becomes important. Then some investigations has to be done by the emergency team. So at that point of time, it will be very useful. Again, if your patient is in ICU, you can't go and patient is on vent. You can't keep doing all the detailed examination at that point of time. Then that e-version will be very helpful.
Right. Somebody asked.
Any PDF? Yes, PDF is available on the website, and it is a 3-page PDF which explains everything. And I think this is
This one, yes, yes.
this one is the 3 page. You can go to the ACI spinal injury, and it is uploaded there.
There is no more question in the chat box. Then we can wind up the session. Thank you, Dr. Abhinav, for a beautiful presentation and clarification to all the questions. This ACI scoring is a continuous evolving process. We have to be updated with this, and we should have repeated discussions in the webinar on this ACI impairment scale assessment system. So this is Abhinav's second presentation. I hope we'll expect some more presentation in future also. Thank you,
Sure,
Dr.
sir.
Abhinav, for accepting our invitation and presenting a beautiful talk, especially clinically very much important for the students. And I must thank to my fellow colleagues of my department and the association members of Odisha Association of Physical Medicine Rehabilitation, as well as the PR team of IAPMR for providing us this Zoom platform for organizing such webinars, especially for the young physiatrists and PG students. I hope we'll continue this webinar for the interest of the students. Thank you very much for all attending this webinar, and especially thanks to Abhinav. Thank you very
Thank you,
much.
sir.
We
Thanks.
can.
Thanks, everyone.
Okay. Thank you. Good night.
Good night, sir.